أجمعين.
السلام عليكم. Is it going to be recorded إن شاء الله?
Recording is started.
Yeah, إن شاء الله بإذن الله. يلا بسم الله. Start عطرات. I think there's no problem with sharing the document. Sister Saadi, everything is fine إن شاء الله.
Yes.
الحمد لله. يلا بسم الله. Let's start.
So Jazakallah khair, Dr. Sadia and Dr. Hina, for taking time from, I'm sure it's crazy busy right now for you both and for your families. May Allah protect you and make your work easy for you and protect all of us, inshallah. So thank you so much for agreeing to do this very, very important topic. And last week, the few minutes you spoke, Sadia, it was clear that this is really a fard for us to take care of this matter, inshallah. So the agenda, inshallah, we'll hand over the mic to Hina and Sadia. They will present. Keep your questions till the end, just to keep the presentation flowing. I'm sure there are lots of questions which they will give time for at the end. And Ustada Huda will make a dua for all of us, inshallah, and for everybody at the end as a conclusion. So Bismillah. How are you both?
Well, I just wanted to know, can you see this, my share screen?
Yes.
You are able to see it, because I can't see it. Okay. All right, inshallah. So I will start. Assalamu alaikum wa rahmatullahi wa barakatuhu.
Wa alaikum salam wa rahmatullah.
Okay. Inshallah, I hope and pray everybody's doing all right. May Allah subhanahu wa ta'ala keep us, our families, and our loved ones safe and free from harm during this time. Ameen ya Rabbal Alameen. So there'll be two parts to this talk. Inshallah, I'll be talking about the MOLST form, which is basically a form that is effective immediately. It is for care it's about your care right now. It's usually used for people who are very sick and who want to determine what their end of life options are. Sadia will follow up with a talk afterwards, and she will talk about advanced directives, inshallah, and that will pertain to future planning of your healthcare. So inshallah, I will begin. It's MOLST form, which is a short form for medical orders for life-sustaining treatment. And when we talk about life-sustaining treatment, we are basically talking about any treatment that tends to prolong life and to prevent death. So these are basically treatments that are taken, if they're not taken, it can actually hasten the patient's death, and the patient may die over a period of days, seconds, weeks, or so on and so forth. So I will share a video with you after the slide. So pertaining to this form, when we talk about life-sustaining treatments, a big part of this form, the most important part of this form, is talking about resuscitation. When we talk about resuscitation, we actually mean that a person has been found without a pulse. He's not breathing. He's basically clinically dead. And what measures are taken by 911 or medical people to try to revive the patient and basically bring him back to life. And I will show you a video after the slide, inshallah. So that is a big part of the form. That's on page 1. And the other treatment options that this form deals with is blood transfusions. For example, if you've lost a lot of blood internally for some reason, God forbid you've had an accident, or there's been a surgery and you've lost a lot of blood, blood transfusions are given to patients to ensure that the blood level is kept at a critical level. So you can live. If the blood is not transfused, then there's a risk of the patient getting sicker and may actually lead to death. It also talks about artificial nutrition and fluid when the patient is dehydrated or is not able to eat or drink by mouth. Those options are discussed in this form as well as dialysis and other treatment modalities, other medical workup that can range anywhere between just drawing your blood to find out what's going on with you, then going on to other aggressive measures like CAT scans, MRIs, biopsies, and other procedures. So I'll touch base with all of those in the next few slides. So this is the video that I want you guys to see. Can you guys see it?
Hi, Mr. Jones. My name is Michaela.
Are you able to see it?
Yes.
Mr. Jones? Somebody call for us.
Sisters, can you please have your mics on mute?
So I hear it. I hear the video, but I don't see the video. I just see the link for the video.
The video hasn't started playing yet, but if everyone could keep themselves on mute, I've muted everybody, but some people are unmuting themselves. So if we can keep everyone on mute so that we can hear Saadia and Hinna clearly through the presentation. Jazakallah khair.
Can you see it now? Are you
Yeah.
able to see
Yes,
it?
yes.
Alhamdulillah.
Yes.
Okay.
Yes.
So this video is they're finding this patient without a pulse, without breathing. So he's basically clinically dead. So now the personnel will come and it'll go show you the steps on what the personnel do when they find somebody like that. Just so you guys can have a visual idea about what goes on.
Hi, Mr. Jones. My name is Michaela. I'm going to be your nurse today. Mr. Jones? Mr. Jones? Somebody call for, I call for a code. I can't feel a pulse. Okay, I got the defense. They're calling a code. Okay. Yeah. If you're, like the pads in. You know, if your compressions are effective, it looks like you need to get on the bed. Okay. Why don't you try that? Is that helping? Yeah. Okay. Until I find a stool. As soon as I'm done lifting up the pads, I'll try to get on. Okay. Deeper. Dr. Cart, do we have a rhythm? Just attach the pads, so I'm not quite sure what his initial rhythm is. All right, there, we're getting chicken signal. Can you hold compression so we get a rhythm check? All right, looks like we get back on while we're charging. All right, go ahead and clear. And shot. Get back on the chest. 1, 2, 3, 4, 5, 6, 7, 8, 9. Great compressions, Meredith. 25, 26, 27, 28, 29, 30.
Did the thing come undone?
1, 2, 3, 4, 5.
Anesthesia?
We're gonna need an airway. Mary, a little deeper, please, on the compressions. I'll relieve you. 21, 22, 23, 26, 27, 28, 29, 30. Right. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, go ahead and keep doing the compressions while he intubates. I'm right behind you, Meredith. Do we have an airway?
Yeah,
A little deeper on the compressions, please. Excellent. Okay, we're switching to continuous now. 1, 2, 3, go. I'll get the back one. Great swab. Okay. We're going to deliver another shock in 40 seconds. Slow down the ventilations. Make sure you're only doing a breath every 6 or 7 seconds. Tell me when you're ready, Meredith. We lost the connector. Can you check all the connections, please? Great compressions. There we go. Good job. Count to 3. 1, 2, 3. Up. Good. Do you want me to get any meds for you? Excellent. I'd love a milligram of epinephrine. Sure. And then we're going to go ahead and charge the defibrillator. Keep doing chest compressions. We're going to take a look at the rhythm. I'll go ahead and give you. We're not connected. Can you make sure my pads are on? Keep doing chest compressions. And I'm charging. 1 milligram of epi given. Excellent. All right, I need everyone to clear so we can do a rhythm. I'm ready for the next one. All right, it looks like we've got an organized rhythm. Can we feel for a pulse? I feel a pulse. I also feel a pulse. Excellent. Excellent job. Okay, let's cycle a blood pressure cuff. Okay.
I'm trying to find out how I can share the screen again.
Just hit the green button at the bottom to share screen. And then when it pops
Okay,
up,
got
the
it.
big screen, that allows you to share. And if you want the audio to be a little clearer, look down towards the left side of where you're sharing the screen. It has 2 buttons. It says share sound or something. And if you click on those, the sound will be crystal clear for us as well.
It's not clear right now?
It's a little bit distant, but if you do that, it's the same audio for all of us.
Where do I see that?
Before you actually share, when you upload the share screen, when you just start to share it, it's, do you see the two buttons on the side, on like the lower left-hand side?
I see
Maybe.
mute and stop video.
Hit share, but don't select anything. So
Okay, got
that
it.
big white pop-up screen,
Right.
then you see it says something like sound,
Mhm.
share sound for all participants or something, like you would click on those.
It
And
just
that would
is share computer sound. Is that
yes,
what?
yeah,
Okay, got
that's it.
Oh. You can see my screen now?
Yes.
Yes.
You can see it, okay. Okay, so what you guys just saw in the video right now was a resuscitation attempt. So you were able to see that they were doing chest compressions on this patient, and that was followed by electrical shocks. You were able to see that, right? And then you saw the gentleman coming in, and what he was doing is he was actually opening the throat and putting a tube in the patient's lungs and bagging the patient. And eventually that tube that is in the lungs would have been connected to a breathing machine to help the patient breathe. So this is the basically three parts of resuscitation. You have chest compressions, you have electric shocks, and you have intubation, that is the tube in the lung. So for the purposes of this form, the MOLST form, again, medical orders for life-sustaining treatment, it talks about this resuscitation effort. It is a medical order that is signed by a physician or a nurse practitioner. And he does that after he discusses with you and your family members to find out what your preferences are, what your treatment and goals of care are, that he ticks off all the checks on that form. And once he signs it and dates it, is effective immediately. And again, it is for this moment in time that these orders will be carried out. A copy is placed in the patient's chart, and a copy is given to the patient. And the recommendations are that it should be kept in a place in your house where everybody can easily retrieve it. Some people just put it on the refrigerator, or it's in a very easily accessible place in your house, and your family members know where it is. So God forbid something happens, 911, if God forbid ever they have to come to your house, the order is there for everybody to see, and they can carry out your wishes based on those orders. These orders can be changed at any time. If at any point in time you change your mind or you change your treatment goals based on whatever is going on with you clinically or not, then you just talk to your doctor. The doctor voids the previous MOLST form, fills out a new one, signs it, and makes that effective immediately. Now, this needs to be very well understood. Not everybody knows that. Even some of the doctors don't know this. But legally, in the state of Maryland, if you don't have these things, if you are unable to make healthcare decisions for yourself, this is determined by a physician. By basically two physicians, they can determine that, for some reason at that point in time, you're not able to make healthcare decisions for yourself. If you cannot do that, you do not have a healthcare power of attorney, which Dr. Sadia will talk about in advanced directives. If you do not have those advanced directives and you do not have a previous MOLST form filled out, a family member cannot withhold these treatment options for you. For example, if God forbid something happens to me, I'm unable to take care of decisions for myself, make healthcare decisions for myself. I do not have a healthcare power of attorney assigned to me. I don't have a MOLST form filled out. I don't have advanced directives. And something happens to me, and my husband or my family member cannot come and say, do not resuscitate, this person, do not resuscitate, do not give blood transfusion, do not do dialysis on me. So they do not have that power if these things are not met. There's only one exception. If your doctor thinks that towards the end of life, you're that sick that any medical treatment given to you would be ineffective, only then, with the permission of the doctor, can you withhold treatment. Otherwise, if you don't have these things, you don't have capacity, you don't have the MOLST form, you don't have an advanced directive, you don't have healthcare power of attorney, nobody has the legal right to withhold any treatment from you. Okay, so people who have very set goals that they do not want this treatment, it is very important that this form is filled out so their treatment and their wishes can be carried on. So who should have a MOLST? So like I just said, people who want to avoid certain life-sustaining treatments. For example, there are people in my family, they're elderly people, they're sicker, and they have made it very clear to me that they do not want to be resuscitated. God forbid something happens, their heart stops, they are to die. They want the nature to, so Allah subhanahu wa ta'ala to take its course, and they do not want to be resuscitated. So they, they've said it to me, and we have to make sure the MOLST form, it is stated in their MOLST form. Jehovah's Witness are another example. For example, they do not like blood transfusions. It's against their religious beliefs. They do not like to contaminate their bodies. So people like that, they don't want blood transfusion. That needs to be clearly documented in the MOLST form. Elderly people who live in the nursing homes, in healthcare facilities, when they're living in the nursing home, or they're being transferred from a hospital to another healthcare facility like a rehab center or a nursing home, then by law they're required to have a MOLST form with them. I would recommend people who are elderly, who are sick, and who want their wishes to be carried out. Our people in our families, our parents, our grandparents, our uncles and aunties, they should think about this. We should start talking to them and finding out exactly what their wishes are. Because honestly, we don't talk about these things. We talk about life in general. We talk about death, alhamdulillah, in our religion, through the Quran and the Sunnah. But do we actually talk about what happens when people are actually dying? What would they want to be done for themselves? So I would recommend these people to strongly to talk to the doctors and have a MOLST form filled out. So again, it's all about you. It's about your wishes, what you want for yourself. It's okay to consult with your family, with your spouse, with your friends. However, it is a decision you will make for yourself, and it depends on your goals of care and what you want for yourself. Once this form is signed, all healthcare facilities across Maryland have to abide by it. Again, it's a medical order that is signed by your physician, so they have to abide by it. So this is what a form looks like. The first part of the form talks about who the doctor is talking to. Is it the patient? Is it the healthcare agent? Is it the healthcare power of attorney, or just a family member, or the parents? The second part, the first part of the form, the first page of the form is the most important part. They say it is they're talking about resuscitation, whether you want to be resuscitated or you don't want to be resuscitated. Again, when you say you want to be resuscitated, that means you're agreeing on three things. You're agreeing that you would want chest compressions, you would want electrical shocks, and in case, almost always a part of it is to put a tube in the lungs and connect it to the breathing machine. So you're saying yes to all three of them. If you say no, you do not want to be resuscitated, you're termed as what is called as do not resuscitate. Also very common terminology in the medical field is called DNR. So you consider DNR. If you do choose no CPR, if you do say you do not resuscitate, you still have a couple of options. So no CPR means they will not do chest compressions on you, and they will not give you electrical shocks. But you can still have the option to intubate. Do you want the tube, in case you have difficulty breathing or you're not breathing, do you still want them to try to put a tube in your lungs, connect you to the breathing machine, and see if you can be resuscitated through that? Or you do not want to be intubated at all. But you do not want the tube in your throat, but you are saying okay to having an external mask placed on your face, which is still hooked to a machine, but nothing is going in your lungs. So it is not an invasive procedure. It is just a mask, and they can give you a trial and see if that will help you breathe or not. Or you can say, no, I do not want resuscitation. I do not want intubation. So you will be do not resuscitate, DNR, or you will be do not intubate, DNI. So this is what the first page of the form talks about. Now, just one caveat for this is, if your MOLST form does not say do not resuscitate, or they cannot find the MOLST form. If they do not have that, if when 911 comes in, by law, they have to attempt resuscitation regardless. This will not be a time that they will try to call your family members, or they will try to find out where your advanced directives are or what other people think. They find you without a pulse, without breathing, they will resuscitate you until unless there is a MOLST form there, okay? The second part of the MOLST form, it talks about, there are again a bunch of treatments. I'll just go over one of them just very briefly. Talks about if you do agree to having some assistance with ventilation, some assistance with your breathing. So it tells you, fine, you want the tube in your throat, you want to be hooked to a breathing machine, but do you want it indefinitely? Do you want it for a trial period? we have seen patients on breathing machines for years at an end. I mean, they're vegetables, they're people who just laying in bed, not really doing anything, just being turning and fed artificially, and they're basically on the breathing machine for years to an end. So is that an option you would want? Or would you want a limited period, like a couple of weeks, a couple of months, so on and so forth? You can also specify here that you want the external mask, and you want it for a time limit, or you want to use it indefinitely, or you do not want any ventilation at all. Then it talks about blood transfusion. Again, do you want to have blood transfusion to save your life, or you do not want blood transfusion at all? Moving on, do you want to be transferred to the hospital? There are elderly patients, there are members of our families who are very sick, who have end-stage cancer, or for some reason or the other, they want to stay at home. They do not want to go to the hospital. They want to stay and spend the remaining periods of their life with their families. So you can have the option whether you want to stay at home or you want to go to the hospital if you require hospital level of care. The number 5 is medical workup. Medical workup can again range from anything by just doing blood draws or more aggressive procedures like MRIs, scans, ultrasounds, biopsies, and so on.
What would you like to
Can somebody
do?
mute their mic, please? So you can specify here whether you want limited medical tests, all medical tests, or you don't want any medical tests whatsoever. Antibiotics is number 6, and antibiotics can be given by mouth. They can be given to your muscle, or they can be given through your vein. Here you can specify it. Do you want antibiotics for any reason? Do you want it for specific reasons, or you do not want any antibiotics at all? Then it talks about artificially administered fluids and nutrition. Now, sometimes patients get dehydrated for a variety of reasons. They're not eating or drinking, or they have diarrhea or something else is going on, and we give them fluids through their veins. Also, sometimes patients stop eating. Either they've had a stroke, they have severe dementia, or there's something going on with their food pipe that they cannot take in food safely. So they need to be fed. If they're not fed, they can die within a period of days and weeks. So food is given to them, and there are 3 ways we do that in the hospital. Most commonly, either a tube is passed through the nose, or a tube is placed in your stomach directly across the skin to give you food through that, or sometimes the food is given through the vein. Now you can specify that. Would you want to be artificially, you'd want artificial hydration or nutrition, one or the other, for a specified time or a limited time period in this box. The last thing it talks about is dialysis. So dialysis tends to happen when the kidneys fail and there are toxins and fluid in your body, and you can basically die because of that. You can drown in your own fluid and you can die of those poisons. So here you have the option whether you want to have dialysis, if it's medically indicated. Again, you can specify the time period, whether you want it to have an indefinite period of time or limited period of time, or you do not want dialysis at all. And of course, if you don't get dialysis, that might lead to death in a few days or so. Number 9 is kept for any other comments, any other wishes that you may have. The physician will sign this form, will date it, put the license number on, and as soon as the physician signs it, it becomes effective. So this is basically all about MOLST. Again, I highly recommend people who have specific, who are very specific about what they want to be done for them. They should fill it out. Elderly people, sick people, people with lung issues, chronic smokers who've had strokes. I would highly recommend at least go over the form and see if this is something that you would want for yourself, inshallah. I'll open it to questions now, if you guys have any questions.
Assalamu alaikum. Go ahead, Sister Mara.
Hina, the intubation, it only has to be done by mouth. It cannot be done, the tube cannot go by the nose, or it has to be.
There are some other ways to do it, but the most common and the easiest way to do it is through the mouth. I have never seen it going through the nose, but in literature it is there. Sometimes they put an incision on your neck as well and try to get it through there if it's difficult. But most commonly it's done through the mouth.
Is it really painful? Do patients feel the pain, or they're literally not in their, they can't feel the pain?
So usually at the time when it's done, it's done during 2 different times. Either the patient is in very severe breathing difficulty, people are with it, those people sometimes do feel it. But the person who already doesn't have a pulse, who's not breathing, the likelihood of him not being able to feel it is higher. Some patients have told me that they remember it. It's not a very pleasant experience. That's what I hear from my patients. Sadia may have some other insight on that.
Okay. Jazakallah khair.
Okay, so I have a question. Is this only if you are both not breathing and have no pulse? It's only in that situation?
So their chest compression and the electrical shocks are when you're not breathing, and when you're not breathing, you're not, when you don't have pulse, you're not breathing either, right? So so mostly they are part and parcel of the same procedure. However, if you still have a pulse and you are breathing, you are alive, but you're having difficulty breathing, and it looks like that if they don't help you, you might die at any minute, then they can just do the intubation part. They'll just put a tube in your throat and hook you to the breathing machine, but you are still alive. I hope I've made that clear.
Yeah.
That's all.
So, yeah, I have a question. Assalamu alaikum. Is the MOLST form also used for designating, you know, like, for example, that all of these end of life sustaining or life sustaining measures are given to somebody to make those decisions, like an imam or as you know a family member, or is that another document?
So Sadia will talk about that in the next, if we designate a healthcare power of attorney, Sadia will talk about that in detail. No, this is not for that. This is you ideally should be the patient answering the questions, but if the patient doesn't have capacity, then it can be the healthcare power of attorney, or it could be any family member, and they're called surrogates. But remember, the family members will not have a full, full control over what they can take away from these life-sustaining treatment options. Keep that in mind. So it's best for the patient to do it themselves.
Okay.
Sister Hina.
Yeah. Yes, sister?
Okay, this is Sitana here. I had a quick question. So what about the burial? Like if you choose or have some like things that you want about how you get buried.
That's going to be a part of the living will and the advanced directives. It is not a part of this form.
Okay.
This is just for treatment while you're still alive. Okay, you consider it alive.
Assalamu alaikum, Sister Hina. This is Nilofer. What are the risks that one takes if you decide not to resuscitate? You know, if you put that down on this form.
So you're basically saying that God forbid if something happens to you and you don't have a pulse for any reason, it could be a heart attack, it could be a lightning bolt or anything, you are telling them, just let me go. Do not resuscitate me. Do not try to bring me back.
And in your experience, you know, do people last a few days, longer than that? Or, I mean, does it? It
depends. Now, once this is done, once they've revived the patient back. Now, just so you know, some patients come back to life, some don't. We can do this resuscitation for 45 minutes, you know, and so on and so forth, and they don't come back, so they're pronounced dead. But if you do come, if somebody does come back, they usually end up in the ICU with multiple medicines hanging on to you to control your blood pressure, your heart rate, you're hooked to the breathing machine. It depends on every patient. It depends how old, young the person is. It depends how sick they are or how healthy they are. I have seen young people, even older people, bounce back, you know, very fast. It just depends from patient to patient. So it really depends upon your clinical condition, your age, and what you're going into the hospital for. So it varies.
Okay.
It varies.
I have a question.
I think that's why this time period thing, I think it becomes very important if you want to think about it. At least, again, it depends on your preference. If you at least want a shot at this, and maybe they can, you know, maybe they can treat you, put on mechanical ventilation, artificial life support for maybe a couple of days, a week or 10 days, 2 weeks, few months. So it depends upon you, how you would feel comfortable that at least I got a chance. And, you know, if it doesn't work out, it doesn't work out. It depends upon what you want.
I have a question. Assalamu alaikum wa rahmatullah. When they do CPR, is there a maximum time how long they go for the CPR, and they don't exceed that time, they just give up, or how long?
Yeah, again, it varies. It depends upon, you know, it depends upon the team, if you're young or you're old, many things. If we are doing CPR on an end-stage cancer patient, we try not to do it for very long. I think probably we give them 20 minutes or so and see if they can come back. However, they're younger patients, the teams can do CPR for them longer, but the likelihood of them coming back and having, say, a meaningful life after 20 minutes, that decreases. For example, I'll give you an example of Princess Diana. When she was dying, I mean, there are reports out there that they were doing CPR on her for hours, just trying to bring her back. So it just, usually it's 20 minutes. It may be shorter for patients who are sicker, who are totally end stage, and doctors don't think it'll be effective at all.
I thought when I used to work in the hospital, I think they did it for maximum of 30 minutes in the ICU. So that's why I'm asking, because that's based on the doctor's, the physician's decision, right?
Correct. So the team is there. The team, you know, the doctors can carry on. If you're younger, if you're healthier, if you've had an accident and you've lost a lot of blood and trying to resuscitate you and trying to bring you back. So, but usually I would say a safe estimate is 20 minutes.
But so if you use that form, you can put, yes, I want CPR for such minutes, or you cannot do that?
You cannot do that. The CPR does not give you that option. It's only for artificial breathing and other options.
Okay, thank you.
So from what you said, from what you said, that if they are continually doing the CPR, the quality of life is then going to decrease for the patient. Is that so? I know you probably don't want to give your opinion, but what's your general opinion about what's the best course of action for a patient that's reached that stage? Should they just, let it go?
Again, it depends on so many factors. You see, the age, the health, and what is it that they want. So if a 70, 80-year-old patient is asking me, who has cancer, who has lungs, who are permanently damaged, if he's going to ask me this question, my answer would be totally different compared to you or a 30 or 40-year-old healthy person asking me. So, that's why this conversation with the doctor is so important. For example, if a chronic smoker lung person is asking me, I would advise him that we can try to resuscitate you, but the likelihood of you getting off the breathing machine is going to be very low. Is that what you want for yourself? So, it's hard for me to give you the right answer. It depends upon the clinical condition, your age, your health, and so many other things.
Okay. Jazakallah khair.
I think there's a question on the chat. Is there an Islamic advice about DNR or not? I will leave that to Sister Hoda to answer.
Assalamu alaikum, Hina. Do you feel comfortable sharing with us what you personally want for yourself? Because it's really hard for me to make a decision because, I really don't deal with doctors, hospitals a lot. And I think a lot of people here also live their lives like that, just take very good care of themselves. And so it's really difficult for me to even imagine myself ever in that kind of situation. And so my knee-jerk reaction is to say no to everything. Like, no, I don't want none of it. You know what I mean? So I'm thinking, I'm like, but then I'm saying, okay, but I don't have a basis of understanding for a lot of it. So do you feel comfortable sharing with us what you want?
Sure, I can. And I have given a lot of thought to this, being in the medical field, seeing once you are made DNR, once you do not resuscitate, what happens. So my inclination would be to attempt it. Somebody who's younger, alhamdulillah, no health problems. So my thing would be to attempt it and to have life support, but for a limited period of time. I do not want to be on the ventilator for months or weeks at an end. So I would probably just, what I've seen in the ICU, if you're still on the breathing machine for a couple of weeks, the likelihood of you getting off is low, but it still happens. I'm not saying it doesn't. So I would just say, give a limited time period to be on the life support. That's what I would do. I would do everything else. I would do, but the blood transfusion, I would do hospital transfer. I would do artificial fluids. Nutrition, I would do for a limited period of time. Dialysis, I would do. That's what I'm saying. Yeah, okay.
Assalamu alaikum.
Walaikum salam.
My name is Fatima. I just want to share my fiqh opinions on you choosing to move the machines. So if you in an ICU, you should not say, no, I don't want to reset it, I don't want this, I don't want that. You should leave it to Allah Azza wa Jalla's plan. Because if you say it and then they move you in 2 weeks, even if they move you, you're not going to die until your times. So I would be more comfortable if I said I leave it to Allah Azza wa Jal, and maybe some stuff where I would say no to, but it's not that, oh, don't use electrical machine or don't do that. That's just what I was comfortable with it. Thank you.
Jazakallah khair. If that's all with the questions, then we'll leave the floor to Dr. Sadia. Inshallah. Sadia.
Okay. Okay, Bismillah ar-Rahman ar-Rahim. Jazakallah khair, Hina. We are in the midst of a very heavy topic, very hard discussion. What we are doing right now is moving on to advanced directives. So the goal of the talk today, just so that we all are on the same page, is that we want to get familiar with the terms, we want to get familiar with the choices that are available to us, and we want to be comfortable filling out the form. And I just want you to know that this form it has a lot of options. So we shouldn't feel obligated that we have to make the decision now, or, these are very difficult options. I'm not in the position to choose right now, which is fine. The purpose is to get very familiar and to get comfortable with this discussion. And there can be subsequent discussions to that. So I want you to stay with me, and I may repeat few things, few terms, so that we get, to reinforce the important stuff out of it. So at the end of this talk, what we want is that we know what advanced directives are. And first of all, the MOLST form that was discussed, as Hina said, that this is for very sick people, those who are end stage, that there is a medical ineffectiveness there, like, somebody who's stage 4 heart failure, last stage of lung disease. So in those scenarios, there are some things that are medically ineffective. So if we were at that stage, what would we have done? So the MOLST form applies to more acute and ongoing sickness. So having said that, we will move to advanced directives. And why are we talking about advanced directives is that we live in a land where there is this law of the land, that if we don't tell them what we wish, it will not be entertained. Nobody knows. But if we tell them, it will be respected, and it will become a law to respect those wishes. So let me share the screen.
Don't forget, if you want to share audio, Saadia, to choose the share computer sound so that we'll hear it clearly, inshallah.
Okay. Can you hear me clearly now?
I hear you perfectly.
Okay, 1 second.
It will affect the audio. If you're playing a video, the audio won't be as clear on a video. So if you just show pictures, you don't need that.
Okay. Do you see the PowerPoint screen?
Yes, it's clear.
All right. So the point is that, you know, we are in a system where there'll be some decisions made by the doctors by default. And if we don't want those things done, or we want certain things to be done, like funeral or like, you know, no autopsy or things like that, that has to be written down. If it is not written, nobody knows it, what we wished. You know, the video that Hina showed, maybe that person who looked like in his 80s, very debilitated, maybe he didn't want what was being done to him because of the medical ineffectiveness. You know, if you are told that this will lead to a persistent vegetative state, like you are living like the person is dead, but is attached to a tube to let the breathing in and out, and is attached to a machine to give the heartbeat. The person was found dead, right? You saw in the video. So, okay, so we want to be clear about these things. We want to take it, and please take it easy. It's a very heavy topic, but take it easy, go with me, and we will go over the terms and, you know, the form. And it's not as, it may sound intimidating, but it can be very friendly for us. And we'll go through that. Advanced directives. So what are advanced directives? Okay, advanced directives are basically advanced decisions. And what, the advanced directive forms, you know, that the discussion started that we want to do a talk on advanced directives. The advanced directive form is basically the when and why of our decisions. So if we are not, because, you know, as I said, we are in a system, and I'll give you the real life examples, not as a physician, but when I was called as a community member to help people to take decisions. And, you know, in some scenarios there was time, in some scenarios it was too late. Things were done that were not supposed to be done. So, or, you know, the things that were not supposed to be done were being done. So, so the advanced directive, the first part is when and why. Whenever we are not able to make those decisions for some reason, that we are too sick, we are unconscious, we went through an accident, or we are incapacitated. That means we do not have the capacity to make decisions. For example, you know, patient who is acutely confused or has dementia, Alzheimer's. So, you know, that these are the scenarios in which the advanced directives will be a good roadmap for people, for our family, for the doctors, for all our caregivers to know what we wanted and what we did not want. And we'll go through what are the choices, so it will become more clear later. How do we decide, you know, how do we make those decisions? Like Bhaiya was asking, you know, what do we choose? I just received a text from a friend that, you know, what do I choose for my mom? So the thing is, we make these decisions based on our religious beliefs, our family values, about what are our overall goals. And then on top of that, you know, what particular illness, this is so critical, what particular illness you are going through. So if somebody is like a, you know, 30-year-old asthmatic, he has asthma and he needs to be intubated, you know, every effort has to be made to intubate that patient. And, you know, the CPR that you mentioned, you know, there are rounds of CPRs. There's a certain protocol to do those CPRs. So he'll go through all those rounds because he was a walking, talking person. He had a job and he just collapsed because he didn't have his treatment with him, and everything has to be done to treat him. Now, there is a patient who is a 90-year-old in a nursing home who has had a couple intubations in the past, who had been in the hospital back and forth, 3-4 times, and he tells his family that, please, you know, give me some comfort. So in that scenario, the goals will be a little different, you know. We are not debating about, what's right and what's wrong, but it's about the values and the wishes and, how we can avoid unnecessary stuff. It's not about doing everything. It's about doing the effective thing and doing the best for that patient. Okay. So when we are filling out the advanced directive forms, first we have to do that. We went through the MOLST form first because that's the end piece of it. That's, in acute illness and in a 911 situation, that's what you need. And prior to that is the advanced directive piece, which we can start filling out when we are healthy, when, alhamdulillah, we have the ability to make those decisions, and then we'll move on. So what is important to us? And, quality of life differs for everybody. There can be different measures, different goals. Some people want to be kept alive as long as possible, if, whether it's on machines or they are suffering, they are too sick to talk to their family or friends, but they do want to be hooked to the machine and to be intubated. Until there comes a time when the doctors decide that it is medically ineffective, that Hina mentioned, that you have to withdraw some treatments at that time. So was that time period in between when, you don't have breathing and you don't have a heartbeat, you are attached to tube, was that necessary at that time? That's the question. Now, next is there are some people who focus on quality of life and being comfortable. They prefer a natural death and they do not want to be kept alive on machines. So that is one category. Other people fall in between. Like, they want, I am very sick. And if it comes to the point that I have to have dialysis, I can try 2 weeks, but it's not worth it more than that because the infections from the process of dialysis will kill me earlier than the actual dialysis or things like that. There can be multiple scenarios. I'm just giving you that, there are in between, then there is, one side of the spectrum and then the other side. Okay, so advanced directives will basically, they are not a required document. These are all optional. And you have as Hina was mentioning, that you have the right to decide. So you are in control to decide and decide what. That is what we are going to discuss in advanced directives. And who decides for me when I'm not able to make the decisions. So those are the two components of who decides for me and what decisions they will, fulfill my wishes and what decisions to make based on those wishes. And you have the right to say yes or no to a treatment. The classic example is the autopsy. So you have the right to say no to it. That's why we are discussing these things, to bring up these, scenarios. Okay, where do we start now? First is that we want to have a talk like this we are having amongst friends. We want to have the same talk with our family, and we want to print out the form. Now, just so we are clear on this, this is not a legal document. This is not like one legal form from Maryland that is, valid, the others are not. You can make your own advanced directives, but, with certain conditions to it, that it has to be signed and there should be 2 witnesses to it. I want you to please, one thing if you can take from this talk is to choose simple form. I'll tell you where these, and this presentation can be shared, so we have the link. The Maryland Attorney General is the gold standard form that is for Maryland, and anybody who's attending from Virginia or DC, you have your own forms, but it's not that the DC will say, no, this is from Maryland, we will not entertain it. So there is an overlap. And the 5 wishes form is it has very simple language. I like about that is that it has very simple language and, easy to fill. this form is not intimidating. I'm just giving you the pros and cons of different forms, but basically if you pull on Google PDF advanced directives, a lot of things will come up. 5 wishes form is very, very popular amongst hospice and palliative care folks. They are talking to people who are, elderly, who are going through sickness, and the language is, very simple. It has a lot of flow. And as I said, the gold standard that most of us use is the Maryland Attorney General website. Then this National Hospice and Palliative Care Organization, they have their forms, and Aging with Dignity also have their forms. Aging with Dignity is also a very user-friendly form. So we don't want to be, again, I want to say that a lot of people have told me that this form is too complicated. That is not, what we want you to feel. There are multiple forms. Just pick any that looks, user-friendly to you. And choose the one with simple language. By the way, offline, if anybody wants, to go through the form or, have questions, we can always continue that discussion offline, and you can always reach out to us for this. Okay. 3 main parts of the form. I want you to please pay your attention to this slide. This will help us to move through the rest of the slides. First part, who will make the decisions for me when I cannot? Okay, so that is our medical decision maker. I'm going to use a couple terms. I want you to get familiar with those terms. One is healthcare agent, which is the same as our medical decision maker. Another name for that is healthcare proxy, exactly the same. Another name for that is durable power of attorney. Okay, now all these terms are for healthcare decisions. They have nothing to do with money. They have nothing to do with finances. They have nothing to do with property. This is only the medical piece of it. And on the same term, I want to say that, this talk is only the medical piece of it, okay? We are just going to give you the medical information. The law and the Sharia and the law of the land is a totally, another aspect of this. But, what we are going to discuss, it should not overlap or contradict any of that. We are just getting the general idea. And we can always fill this form out by the end of this discussion, hopefully, and the things that we are not ready for, we leave them out. So that is the first part of it, medical decision maker who will decide for us when we cannot. I'm going to go through all of them in detail. Second is what decisions, your healthcare choices, that will be called here as the living will. Again, nothing to do with money, property, estate, nothing. This is the medical living will, which the advanced directives have. This is the main part of the advanced directive form. These are our decisions. We don't have to make all of those decisions right away. We just want to have the control over that, what we are clear about, we'll do this now. And, with time, if things become more clear, we'll keep adding or we'll keep changing. The third part is the easiest part. Is the signature with 2 witnesses. So 2 witnesses can be any adults, aqil, baligh, anybody who can, be the witness for this form. He cannot be the one who we appointed as our medical decision maker, the first box. So anybody who will be making decisions for us cannot sign this form. Anybody, your guests come in the evening, you say, I have done my advanced directives, I need a witness, can you go through it and sign it? Sure. So there is no particularity in that, but the only point to remember is that our healthcare agent, which is also our durable power of attorney, cannot sign those forms as the witness, because he's your party, right? And the witness is witnessing you and the healthcare agent to regarding the form. Okay, now one more term I want to use is that durable power of attorney. We don't want to, complicate this term. Why it's called durable? It's a very interesting fact that, the usual power of attorney, which deals with the money part, is expired when the patient gets confused. when a person gets confused or is not able to make decisions, that power of attorney is not validated. However, in medical scenario, the power of attorney that we choose, why is it called durable? Because that one kicks in when we are not able to make decisions. That's why it's called durable. So it's simple like that. So now we understand that it has these three pieces to the form, and the main piece is the middle piece, our decisions, and the second main pieces are who is the decision maker. It can be one, it can be two, it can be three, depending on who is available. If one is not available, then second. Okay, what if I want to make healthcare choices that are not on this form? So that is where some of our, from our family values, from our religious beliefs, from our goals, that's where there is an area in every advanced directives where you can mention, you can write down anything else that is important to you or ask to refer to your healthcare agent. And the particular example is funeral arrangements. So you can say, in case of my death, please contact my healthcare agent 1, 2, 3 for my funeral arrangements. You don't have to specify those arrangements now. Or you can contact my spouse for my funeral arrangements. Do not make any decisions until my spouse is consulted at the time of my death for what are the next steps. So you just have to, paraphrase that of what to do next. So that will be then taken into account. That is just one example. Okay, what if I have questions about my form? You will have questions about the form. We still have the questions about our form, just like, the things that are clear, we'll do those, and the things that we have questions about or we are not sure of, or the things that, will become more clear with time, we leave it for that. It is okay to skip any part of this form if you have questions or do not want to answer. So please remember that piece. It doesn't have to be a perfectly filled, complete form. It will be very valid even if there is one point in it. Maybe just the name of the healthcare agent, or, that I don't want any autopsy. That can be your complete advanced directives. If you're okay with the rest of it as it comes, no, you can leave that out. It's always good to ask your doctors, family, or the people you trust. It's okay to do the shura about that, and especially in a particular illness. In a particular illness, what is the prognosis? What is the expectation? What is the life expectancy? All those things. Once you know from the doctor, from his point of view, then it becomes easier for you it becomes more clear. This part, I'm not too keen on it, that lawyers can help too. This form does not give any legal advice. So lawyers, more than, if you have a particular question, you can involve the lawyers, but we want to keep it simple. And, your doctor will be the first person to, if you have questions, to refer to complete this form. What should I do with this form? You want to share it with your family. Please do not keep just the original in a bank account. That's not going to help. We want to make copies. We want to share with our family. We want to share it with the healthcare agents. Obviously, they'll have the copies. We want to share it with our doctor, a close friend, and to start with, just hand it out to your spouse, or these are the people we want to share it with. Just keep the process simple. And then, if there is a hospital admission, then, make sure that the people who are taking care of you, they do have a copy. The family should bring a copy of those advanced directives so that they are in the record. Okay. Now we are back to, the three boxes that we discussed, I talked about. That the first part is, who will make the decisions for me when I cannot? So the healthcare agent, the other name for that is healthcare proxy. Another name is durable power of attorney. It's durable because it will kick in when we cannot make our decisions. So it's durable. Okay. Now, these are only health decisions. That has, people have their power of attorney for financial. They have a separate person A in the family for financial POA, and a separate one for medical, who's the durable power of attorney. So we don't want to talk about the other piece. We are focusing on this, and both are different. As I said, this person cannot be the one who will witness to sign the advance directives. Okay. Then a few more things about the decision maker for us, who will be our durable power of attorney, healthcare agent, healthcare proxy, should be 18 years of age or older. She or he can talk to you about your wishes, can be there for you when you need them. You have to have that relationship of trust with them. Will follow your wishes and do what is best for you. These are two different things. So when the decisions are to be made and the doctors say this is what's going to happen, and we do this or this. So how I explain to my patients is that the best way is, first, number one is to be in the place, not to think what you think is right. The first is to be in the place of this person and see that if he was able to make decisions at this time, what decision would he make in his best interest at that time? What would he make? And based on your discussions with him, based on knowing him enough, then you will do that. And then if you cannot come to a conclusion on that, then you decide that, okay, for this friend of mine, if I do not know what he wanted in this particular scenario, what would I do which is best for him? So these are two different things. But the point is that we have to respect the wishes of the person and do whatever is in his best interest. And then this person should be trustworthy to know all about your medical information, and this person should be available to ask questions to the doctors. Tell me, what is the prognosis? What do you think if you do this? What is the outcome? What quality of life would he have after this? If we do not do this, what next? So he should be able to be upfront and talk about these things. And please remember, we live in a system where they expect us to ask those questions from them. If we do not ask, we do not get the answer. So they are liable to answer to us, and it's totally fine to discuss. Sometimes a lot of patients with some malignancy, they follow their oncologists, and when they come to us as primary care physicians, they never had that that discussion with the oncologist of what's next, or what happens if you say, if I choose not to do this, or if I choose to do more aggressive. They come to us and ask us, which becomes a little overwhelming for us. So I always encourage them that talk to your doctors, know your prognosis, know your choices, and then the healthcare agent has an important role to do the same. Very important is that the decision maker, our healthcare proxy, our medical decision maker cannot be our doctor or somebody who works in the same hospital or clinic that we are affiliated to. It can be our family member, it can be our friend, but not our doctor. Okay, some of the examples of the decisions that the decision maker may make for us is, I'll just fly over this slide, is that, some of the invasive surgeries, this medicine versus that medicine, invasive testing, which may have pros and cons, risks and benefits, the usual stuff that they will ask anyways. So the healthcare, agent will also be asked about these things. To request for life support, that, I want this done. I do not want this to get started. Pain management is a whole different scenario that, how much pain management and the goal of comfort and to avoid suffering, these things, So why I'm bringing this up is that, in a particular scenario, alhamdulillah, most of us, alhamdulillah, we are, in decent health. And however, any of our loved ones, if they are in that situation, like Hina was mentioning, these things should be talked about, that how much suffering do we want to go through when the medical treatment, will not, the quality of life will not be changed. Then the decisions like, admission to an assisted living facility, to a hospital, to hospice, or transition to a nursing home. These are some of the decisions that, our decision maker will be making for us. And the release of our medical records, they have the power to do that, to release from one hospital to the other. Then, obviously to advocate for your healthcare rights and wishes, and to apply for further insurances. If, we cannot make the decisions, but we qualify for further Medicaid, for further help from the state, they can apply on our behalf. Okay, just so you know that the healthcare agent can be our spouse also. Obviously, by default, all these questions will be answered by, or all these decisions will be made by our spouse. Okay, so that was part 1 of the form. Now we move to part 2, which is the bigger chunk of it, is that part 2, living will, what decisions? So this, what decisions are the healthcare instructions? We had the healthcare decision maker, now we have the healthcare instructions. So what decisions are in the advanced directives that we can put in black and white? The ones that we choose to, and again, leave blank whatever we are not sure of. So living will here is the medical living will, nothing to do with property. And basically it deals with these bigger, picture things. What if my heart stops? If somebody finds me basically clinically dead, and what next? Artificial feeding, pain management, there are different choices. We can fill out trials. There is one to do nothing, third to do everything in between. So, we can start thinking about those things. Okay, so when we have a living will, then we have a roadmap, that the doctors can follow, the family can follow. The doctors use this as a guide to manage our care, and the healthcare agent also uses it as a guide, that what do we want to get fulfilled. Then types of the treatments we want and types of the treatment we do not want. Now this last box, why I brought this up, I can, I didn't want to bring it up, but the only reason is that these terms are used in the Attorney General form of advanced directives. These are complicated terms. If we do not know them, that's fine. But since they are mentioned in that form, I don't want you to get, concerned about that, what is this? So I'll just give you an example of the same person who goes from end stage to terminal to persistent vegetative state. These are 3 different stages in which they will ask the questions about, that resuscitation part, the bigger picture, the resuscitation part, the pain management, the artificial feeding, and to attach to the machines, intubation. So to make those decisions in end stage versus terminal stage versus persistent vegetative state. Again, end stage is like, for example, if we say a heart failure patient who is last stage of heart failure, stage 4, means he cannot get out of the bed. He is at his home, he gets his medications, but he gets very short of breath if he takes couple steps. He has had multiple hospitalizations, but he's there. And he is, one day he has a lot of swelling, other day he's short of breath, third day he's stable, that kind of thing. That is end stage. If same patient gets very sick and becomes so short of breath that he has to go to the hospital and he does not improve, despite of different things that they do as a protocol for treatment of that particular illness, and he keeps deteriorating, he becomes terminal, which means the death is imminent. Then persistent vegetative state is that when the same person is unconscious and he's just like a vegetable, he's attached to machines and things that are making his body breathe and his heartbeat to go on. Otherwise, he's like vegetative. He did not have the signs of life when these things were done, and okay, so just, I hope I didn't lose you here on these things, but these terms may occur in some of the forms. That's why I mentioned these. Okay, this is a simple one. When we fill out the forms, we do not use check marks or X's, anything like that. We use our initials. That's all in this slide. And we draw lines all the way through other statements that do not say what we want, and we do not want to make decisions on them. Just draw lines on those. Okay, so as we can remember, the first part is who will make the decisions. The second part is what decisions. The third part is signatures and witnesses. So we can do either only first part, but the third part has to be done in either case. We can do only part 2, we can do both. Everything has to be attached to part 3, which is the signature and the witnesses. Okay, it's so quiet. You can hear me, right?
Yes, everyone's mic is on mute. That's why it's quiet.
Okay, good. Okay, all right. So part 3 is our witnesses. This is the easiest one. Is about the signatures. 2 witnesses can be any aqil baligh person who can sign. And then healthcare, same repetition, just to remember, healthcare agent may not be our witness. Preferably a person who would not financially benefit by our death or handling our estate and property. Preferably. State to state things vary, but we don't want to make it more complicated than what it is. And one important thing, this is a form, this is simple form in terms of that it does not need notary. It just needs our decisions, the decisions that we can make now, and leave the rest for later. After we sign it, when does it get in effect? As soon as we sign it and something happens, that's when it's in effect, as long as it's in access to the people who are taking care of us. When we are not able to make decisions, if things happen, accident, unconscious, severely sick, that our mentation is not that clear at that time, it is in effect. When does it expire? It expires at the time of death. And the good thing is that we can change and modify any time, and make changes anytime, as many times as we want. Just we want to make sure that the people who got copies of it also get the new copy. And then no one can make changes, not even the healthcare agent. Please remember, the healthcare agent cannot make changes in your advance directives. He can modify the decisions based on how much freedom we give them to make decisions, but they cannot make changes in the original form. And, the good thing is to review these with any change in condition. And if there is no change in condition, every so often, once in a year, you can go through it. And most recent one will be the valid one. Okay, so on the Attorney General site, there are wallet cards that are, you can print. It's like a paper that you can print. It has the marks where you can just trim it and put it in your wallet. It's the size, it's a small size like a credit card. What it tells is, if things happen to a person, if there is an accident on 495 and they look into your wallet, it says, I have advanced directives. My healthcare agent is this person, call this number. So, that's what the wallet card says. You can print that wallet card, just, Google it or go to this site that is already mentioned in the earlier slides. You can have that copy in there. And please think about these discussions, if anybody in the family can benefit from these discussions, if not us, any like Hina mentioned, any elderly in the family or somebody who's very sick, pass this on, because it may not apply to us now, but it may be that somebody else needs it like now, depending on their health condition. Okay, so this is basically, when do we want to review this form again? When is the again part? So if you change your mind about your healthcare choices, or if your health changes and you come to a conclusion, or your medical decision maker, there is a change in that, or if there is a divorce, there is a scenario that there is a divorce, then the other person will no longer be there to make the decisions. So you want to make modifications to that, and then make sure that the new form is given to the right people, and just tear apart the old forms, trash them, and tell the other people who have the copies also to trash those. Where do the copies of a completed advanced directive go? Completed means any decisions that you made, and to crossed out the ones that you do not want to make. That is a complete form. That will go to your doctor, your healthcare agent, the backup agents, number 2, number 3, to the hospital, and to the family members or friends who should know of your wishes. And you can keep a copy of the wallet card in your wallet. Wallet card will only say that I do have advanced directives, and contact this person for that. And that wallet card, please, should not be mistaken for a DNR card in the wallet. That is totally different. Overriding of a living will, as I said earlier, no one can override a living will. You say, I want this to be done. There is only one exception, which is called futility of care, medically ineffective, in which 2 doctors decide in a medical setting that the care that is being provided is futile. It's not effective at all. So they can withdraw that care despite of what's in the advanced directives. That's a very, last scenario in which, things are very obviously not working, For us not to get confused, nobody will, the doctors will just decide that. It will be in a very obvious situation in that, that's it, this is ineffective. And the doctors will decide, irrespective of that, what's in the living will, the medical living will, the advanced directive. But that is a very, very seldom it happens. Okay. If we do not have a surrogate, if we do not have our healthcare agent available, number 1 is not available, number 2 is not available, number 3 is not available. If we have those 3, then, there is a hierarchy that, in US, which will be different from what we may expect, that they reach out to. There is always room for discussions and all, but I'll just throw it out there so that we are aware of who is the surrogate decision maker if there is no healthcare agent or healthcare agent is not available, or by default, who will make the decisions. First is if somebody has a guardian, a court-appointed guardian. And somebody, for example, there is an autistic adult who has a court-appointed guardian, so the guardian will be contacted first. If there is no guardian picture, then the first person, if there is a problem, my spouse will be consulted. If the spouse is not available, my adult child will be consulted. If not, then number 3 is a parent. If not, then any brother or sister adult will be consulted. If not, then an adult grandchild, the grandchild who had been involved in the care of the patient, who knows the patient, who had been in touch with the patient, who cares for the patient, will be consulted. Then next is, if they cannot find anybody, is there any close friend who's available to take to discuss the decision making? And the last is the guardian of the state, which is the properties, And if there are multiple candidates available and there is discrepancy of decision making, spouse says, I want this to be done. And the adult son calls from Florida that, no, I want this for my mom to be done. Then first of all, they have to figure it out amongst themselves. Spouse all will have a more power to make the decision. It's good for them, those parties, to talk to each other and come on the same grounds. Otherwise, the doctor gives their opinion, and usually the cases are resolved with multiple points of views from the family. Sometimes, it happens that a good discussion from the doctor with the family members and those who are not available in person, on phone, like a joint meeting, and that some folks are on phone and some are in there. Then whatever the doctor says, sometimes it can help. They can play a major role in helping the family to make a decision that's in the patient's best interest, and the preferences will remain the same as I'm showing on the slide. Okay. Now, based on what I talked about so far, I have a little quiz. For that, maybe you can unmute or you can put in chat. I'm not very comfortable looking at the chat and looking at the slides together. So maybe Sister Alia can help with that. However you guys want to do. So.
उन्होंने क्या ये प्रोग्राम हमने क्यों नहीं अटेंड किया इसे? Yeah,
Okay.
2 to 4.
No, that only says
I came and
Okay, here is our first question. Does the advanced
नीचे पूरा
directive...
कर दे हैं तुम्हारा तो बहुत ही बड़ा है.
Okay, I think better if I mute everyone and then just allow them to unmute to answer.
Okay.
Because we see what happened. Many things happening in the background. SubhanAllah.
Okay, so the question is, does the advanced directives form need to be notarized?
No.
Yes, so the correct answer is no, it does not need to be notarized. Thank you, Jazakallah. It's simpler than that. No notary needed, only 2 witnesses needed, and they can be anybody. Can your physician be your healthcare agent?
No.
No.
No. Excellent. Your physician cannot be your healthcare agent. These are just yes, no questions, just to reinforce the points. It's not a Muddakir exam. Are do not resuscitate orders covered in the advanced directive form?
No.
No.
Yeah, correct. Do not resuscitate orders are what Hina discussed. they are not part of the advanced. They will tell about what, you know, when you read the advanced directives, you would know what the DNR orders would look like, because it will say, I don't want this, I want this, I want it only for this much, in this condition, you know, in different scenarios. So the form has those options, but it will not give an order. Order is only by a physician, which Hina discussed. That form is the order. So just so we know that if you know, there is a 911 call and the patient has advanced directives right there by the bedside, and he does not want any resuscitation, and if EMTs folks come, they have the order to resuscitate anybody unless there is a DNR order. So the order, MOLST form is the DNR order, which is separate from advanced directives, but advanced directives will reflect what the DNR order would say. Once completed, can you make changes to your advanced directives forms?
Yes.
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 Yes. So you can make as many changes as you want, as frequently as you want, but please make sure you don't keep those changes with yourself. You pass it on to the people that originally are supposed to have the copies. One more, I think. Is there only one single standard form available for advanced directives?
No.
Correct. So there are multiple forms, and not to get confused, just, you know, Google them. You can, the first slides that I showed, the State of Maryland one, the 5 wishes one, the hospice and palliative care one. These are the usual ones, and you know, some of them have simpler language than others, but the basic gist of it is exactly the same. So now I will open to discussions and questions. So Sister Alia, maybe you can moderate that if there are any questions in the chat or otherwise.
One question from the chat is, let me go up a little bit. Who should be my healthcare agent? I don't know if you saw this. This is from 3:30. Someone's asking.
Sister Alia, can you tell me how to go back to the chat?
It should be something at the bottom of your screen. If you kind of hover your mouse over the bottom, there should be a box for chat. And if you click it, it should pop up for you.
Is it okay if I stop sharing the PowerPoint slides?
Sure, if we don't need to see anything, sure.
Okay. Okay, what's the question?
It's from 3:30, so you have to go up a little bit. It's like a few questions up. It said, who should be my healthcare agent?
Okay, so, you know, we went through it in a general sense that healthcare agent will be the person that we trust. It can be our family member, it can be a friend, and she should be willing to be your healthcare agent, you know, and to stand for you and to make the decisions when we cannot make those decisions. So, for example, I want Sister Alia to be my healthcare agent. You know, my first healthcare agent is my spouse. My second is Miss X. My third is Mr. Y. So it depends, you know, how you want to choose it. But if we have choices, if you have any particular question, we can go offline and discuss, you know, how you want to categorize those. Any other question?
I have a question.
Yes.
Can your healthcare agent be somebody who's not physically here but can be reached by a phone or something, or no?
Absolutely, yes. They don't have to be there in person.
Okay. Okay, Jazakallah khair. Also, can you send us the the sites for the forms, for both forms, please?
Okay, so what I'll do is I will, again, send the sites that I think, are mostly used in the Muddakir group. Is that okay?
Yes,
Or I can.
Yeah, that's fine.
I will
Jazakallah
forward it,
khairan, yes.
inshallah, to the other groups. No problem. Bi'idhnillah ta'ala. Anything that would help, I will forward it to the other group.
Sister Alia, can you go through the chat and let me know if there are any more questions?
Yes. Someone else at, let me see, let me go down a little bit. It was, okay, every time a change is made, does it need 2 signatures?
Every time a change is made, does it need 2 signatures? Yes, because you have to update the date.
Okay. And there's another question. If you don't have a MOLST form for yourself, wait, trying to, if questions come in, then it moves up. If you don't have a MOLST form for yourself and end up being intubated, would having the advanced directive forms be of benefit for limiting the duration that you will remain intubated or on a breathing machine?
This is, I'll tell you both the scenarios. This is a little complicated. What happens is that we cannot withdraw a treatment. We cannot take away a treatment from a person unless it's written as an order. But in case of that, if in advanced directives, it clearly says, I do not want to be intubated, in no circumstances, then the physicians and the family can decide on that. It becomes, in real life scenario, it can be a topic of debate. Even the families start arguing about it, but respecting the wishes of the patient. If the intubation is withdrawn, there is no legal problem with that, because that is what they wanted. And in circumstances when it's not available readily, it can be discussed with the intensivist and readdressed.
Okay, another question is really an advice someone wanted. They said in their culture, this is not something that is talked about often, and they want to know how they could mention these sensitive subjects to their parents.
Okay, so, I try to keep it, I'll give you an example. I forgot to mention the couple examples, please, if we have time. You can give examples to them and at different levels. You don't have to, bombard them with information right away, but we can in one setting say that living in this land, we want to be protected, and in order to be protected, our wishes have to be known. And when you give them an example, you will be surprised at, they say, no, I want this done. And we assume something different. So it's okay to get the discussion started, maybe in steps, and not to just overwhelm them right away. But you will be surprised at what they want and what they do not want. And one thing, please, it's better, whoever that's the sister who mentioned this question, it's better for them to decide these things if they are living here, because you will be the one in a very difficult scenario, God forbid, it's possible that sometimes when our elderlies, do not make these decisions, we are put in such difficult scenario to take those decisions for them when we do not have any idea what they would have wanted to get done, and what is, for us, what is Islamically correct, what had she wanted to get done, what is medically right. So it's very overwhelming. So sometimes you should tell them that, if you don't want the children to go through that, or you don't want children to make the wrong decisions for you, here, let's make some decisions, or let's talk about these choices. I'll give you examples. I'm not going to give you any example of my patients. We do this day in and day out, every day, there is a different scenario, but I'll give you the examples from our community. And, the family members of those patients are right in this conversation right now. So there were, there are these two sisters, elderly sisters in their 60s, early 70s. They were taking care of their very elderly mom. They set up in basement for her hospital bed, everything. That both the sisters would take turns to take care of mom, change her, do this, do that, and I would just visit them as a family, the friend. And, any advice here and there, any discussions and all, just from that perspective. What they did not do is that they did not do an advance directive. They did not do MOLST form for a 90-plus-year-old advanced dementia lady taken care of 24/7 by her two daughters, who wanted, whatever they could, to pour their heart out to take care of their mom. Unfortunately, I remember a few years ago, I was leaving for Pakistan that day on my flight. And when I reached Pakistan, I came to know that, from their discussions, I knew that they wanted comfort for mom, and they were ready for her to pass at home in the comfort, because, the doctors had told them what's the outcome. And the only thing we can do by intubating this patient is breaking her bones. And there is no way that she can come back to any quality of life. It's only going to increase the suffering. So guess what happened? This patient, and they found her unconscious. These two ladies, who the only thing they could think of at that time, which is, the right thing, is to call 911. 911 took away their mom from that basement which was like, they made the best setup for her at that time. They took her to the hospital, nearby hospital. She was coded multiple times, multiple attempts for CPR, and then she was pronounced dead. Did she deserve that at that time? No, because, their family had already expressed that this is what mom wants, but it was not written anywhere. So this is just one example and one scenario. In other scenarios, maybe that was the right thing to do. I'm just giving you one example. So what we want to do these things, please, especially for our vulnerable family members, our elderly. Let's do these things, and whatever their decision is, and whatever you guys decide, but the discussion has to happen, because we live, please, I repeat again, we live in a country where things will be done which we do not want to get done unless it's written somewhere. I'll give you one more example. This is that 90-year-old. Now we have this young brother in his 40s. And he was going through a chronic illness, and his parents, and they were like, this is an example of, perfect family taking care of each other. Long story short, this brother did not have a MOLST form, did not have advance directives. I saw this brother as a family friend, not as a physician. I saw him a night before he passed. He was in ICU of the hospital, and his dad, I can never forget his face. The helplessness that he had on his face, in his eyes, I can never ever forget that. He said, my son wanted comfort. Why is he in ICU right now? This is after so much happened. I cannot go in all that detail of whatever happened. He was supposed to have a surgery, but the surgeon said we cannot even touch him. He can pass on the surgery table if we touch him. So he was that sick. And in that scenario, when he wanted to be home, when he would wake up from his pain, after the sedation, when he would wake up, he would say, "Can I be home?" And this happened in those last 2-3 days when these things were expressed, and the father was like, can he be in some other place where he's more comfortable? Can they stop giving all this and attaching him to all these IVs and all that? So, we had a discussion that we requested that next morning, the palliative care nurse will come and we will make changes, and we'll talk about all that. And the nurse took, it was about 10-11 p.m. that night. The nurse took the request from the dad, that yes, we want comfort for this patient. We want him to be shifted out of ICU, of all those beeps and all that, and IVs and, all the acuity of care. And, Qadar Allah, he passed 4 a.m. that morning, before that meeting happened. So these are, the examples of a younger person, our age group versus a 90-year-old, and he passed in pain. This brother, because see, these are the things. The nurse who explained to me why they cannot give him more pain medicine is that if they give him more pain medicine, his breathing will be depressed, and he will again be intubated, again require intubation, and he should not go through intubation. She was right in her little assessment that she did, but she was missing the bigger picture. She was missing what the dad wanted. She was missing what the patient wanted. She was missing what, mom was worrying about. So basically, again, back to the point that, these forms, we want to express, we want to have the discussion starting from our elderly. If we are not doing for ourselves, let's do for our elderly first, and then think about these things. And please don't feel guilty that you are making all the, if the decision you are making is right or wrong, make istikhara, make dua before you do these forms. And may Allah give us all afia, it's just to protect ourselves, basically. Sorry, I went too long on that, but just wanted to share that.
Can I ask you a question? Okay, go ahead.
I'm sorry, go ahead.
Oh, me, or you can go if you want. Go ahead.
Okay, my question is, are there decisions that are usually taken that are against our deen or our religion that we should be taking care of?
It can happen. And the examples could be that, one big example that comes to my mind is that if there is a very suspicious death, like somebody dies at home, and there is a suspicion of, did he poison himself? What did he do? You can clearly write that you don't want any autopsy in any scenario that happens. In some states, what we say holds more weight than the state law. So, and then, those are some of the things, the blank part that you have in the advanced directives, you can think, when you go through that form, you can think of these scenarios and you can put that stuff in there, or to refer to my spouse for, if it comes to that, for funeral, things like that.
Okay. Can I ask you the question, please?
Yes, please.
Yeah, I just like now with these two examples, I understand that the two forms are very, very important. But like in another situation, if the person refuses to make up his mind, or to her mind, or to make to fill up these forms, and then I thought, like, when we were saying there are circumstances where they do ask as a surrogate person who has a close family member. So in the situation, for instance, of the young man who had passed away and his father had different wishes, I don't understand why didn't they went by his wishes. That's for one thing. The other also thing, when you stated that in cases where the treatment is futile and you know that it's not going to be effective, the physician sometimes make up that decision that these are not appropriate. So again, like why weren't these two measures were taken if it was appropriate?
Okay, so to answer the first part of your question, things can happen the right way, the ideal way that we would want, that the surrogate is told that, it tells the doctor, this is what we want and this is what we get done. In real life, this is the example of real life scenario and the time where time is the essence, where things get delayed because they are not clear. Yes, that brother wanted comfort for him, but at what level, he did not define that. When the surgeon said his last 3 days were, a lot of suffering, when the surgeon said that I cannot touch him, I cannot take him to OR because he's at very high risk of death right through the procedure of the surgery, and then the ICU took care of the rest of it. Now, in that time frame, we can imagine there is a lot going on in terms of their parents are totally confused, and wondering. And when I come in, they are like, what should we do now? I understand that this is important, what they are getting done. Is there any other way? They don't even know other choices. They did not even know that there is a palliative care nurse who exists in the building who can come and talk to them about that. So, when things happen in emergency, there is no, ideal flow of events going on. There are so many things going on at the same time. And in those 3 days, the parents have hope, the parents have so much fear, the parents are feeling helpless, the mom is staying, she's doing anything that she can. And then, in the back of their mind, they are hesitant even to ask that if the patient needs to be intubated with a lot of pain medicine, should we even ask for more pain medicine? But remembering that this is too much suffering for him. So they need to be educated at that time. This palliative care consult should have happened much earlier if we criticize this case, to discuss and to let the families know these are your choices. When things are happening one after the other, the surgeon is saying one thing, the intensivist is saying the other thing, the patient is, so restless. Then at that time, it's very hard, very, very hard for the family to make certain, the clarity of mind is affected. At that time, that's why palliative care is so much on the rise to start parallel to, all these illnesses and all, to start talking to them about these things. There is a whole battery of, the physician, palliative social nurse, palliative nurse, so that they can start talking about these things before things happen, so that the family is clear of what they have to even ask for. They didn't even know what to ask for,
Yeah.
Yeah.
And nowadays with the COVID-19, what I hear is that the people who really get sick and they go to the hospital, they don't allow anybody else of their family to be there in the hospital with them. So how does that even get discussed or known what to do or not to do, or at that point?
Absolutely. This is, something, very dreadful. Unfortunately, that's when, they are totally in the hands of Allah subhanahu wa ta'ala. But the hospitals are doing a good job in terms of talking to them daily. The social workers, they have to, they have their protocol. The MOLST forms have to be filled out and all. And then there are discussions going on the phone, especially the first page of the form.
Yeah,
that says DNR or not DNR or in between, or just the trial of the BiPAP or CPAP. Those discussions will happen on the phones. Do we want these discussions to happen in these scenarios on phones? No, we want them earlier.
Sadia, I want to just say something that as soon as I saw this, the coronavirus spreading across globally, started seeing deaths, even young deaths. So me as a physician, again, I've been in this field, 12, 15 years, we've been doing this, and we do, like Sadia saying, we do this all the time, day in and day out. We're discussing goals of care with the patients all the time. But me, even as a young, healthy person, the first thing I did was I talked to my family about what my goals are. I made very sure that I clarified what I wanted for myself. And the next thing I did was I was talking to Sadia about my advanced directives and going over those options. So this was a reality check even for us. And like Sadia is saying, once, usually when the patient is sick, if it is done in a case of an emergency, 911 is coming and getting you, and especially these days, if they're coming and getting you alone, everything is lost. You don't have time to think. And the doctors are there to provide all sorts of care for you. That's what they're told to do. If you don't have these things written down, you don't have orders written down. So they are going to do whatever they want. They're not going to wait to call you until there's a big procedure going on. So once things start happening, it's very difficult to communicate these things. That's why I think it's so important for us to start thinking about it for us, for our family members, and just make sure our family members know our options and we write it down somewhere. It's very critical.
Absolutely.
Also, so there was a clarification that was requested. Can we clarify that MOLST is strictly a doctor's order? And this came from Dr. Hina. She just wanted us to make that clarification. And there was also a question, do the different states have different requirements?
So, the MOLST form is a physician order. Actually, MOLST form, they don't just do that as an order. The order is preceded by a discussion with the patient or the family. It also has, it's like a worksheet that is given. For example, I'll tell you, if the patient is admitted to a rehab facility, they are given a worksheet by the social worker that explains all those points that Hina mentioned, all the 8-9 points, in more simple language that, if this scenario, what do I want to get done, A, B, C, or A, B, C, D. So they will be given that worksheet. Once they initial those worksheets, that worksheet is brought to the physician. The physician takes from the initials of the worksheet and does his initial on that form that Hina showed you, and then signs it based on the background of what the patient and family decided. Now that becomes an order that cannot be, that is a legit order that goes from nursing homes to the ambulances to home to hospital, and that is taken by even the 911 folks that we have to abide by that, if that answers your question. Yes, MOLST form is available online. Hina had already sent the, we'll send the links again for the MOLST form and other forms.
Yeah, that looks like the last question.
I think somebody, what will happen to a person without a self filled out?
So that must be private to you. I don't see that question. That's the last of the questions I see.
Okay. So if we have more questions to that or anything, just so you know that Hina and I are available in our capacity, we may not be, we cannot cover the legal pieces, but the medical piece, if you have concerns, questions, we are available to talk about those.
I, for one, would like to, I don't have a question at this time, but I would like to say thank you to the both of you for sharing this really important topic with us. I know that this is something that we don't really like to think about, and it is necessary to think about, even from the scenarios that you painted for us, of real life scenarios that happen. And even my grandmother, when she was dying, it's a scenario, something like that. Like they couldn't do anything with her anymore because her colon was impacted and she needed surgery. And if they did the surgery, they said she would become toxic and die. So they just pretty much had to let her, she pretty much was just on pain meds until she finally passed away. But I don't think anyone in the family was, thinking about having forms in place and things like this to decide what to do with her and where she should be and where to make her the most comfortable. So this is alhamdulillah, and especially with the times that we're living in, and the coronavirus and how people are being alone. We need to we need to have something in place. Inshallah. There looks like there's a couple of more questions that did pop up. Someone's thanking you, alhamdulillah, both doctors, for this very beneficial session, and may Allah reward you generously. Someone's thanking you for the reminder. You both, someone's asking for the recorded session. Inshallah, we will. And someone's asking, in the current circumstances, when our doctor's office is closed, how do we get a MOLST signed?
Okay, so to answer that, there are ways to do it electronically. And, you know, DocuSign is an app that can do it electronically. Yesterday, I was looking at, one of the National Hospice and Palliative Care folks. They also have a form. If you Google the form, the PDF form, they can be sent to the doctor to sign it electronically.
Okay, alhamdulillah. Just lots of thanks from many of the sisters. Jazakumullah khair. Thank you for your hard work. Thank you for your advice and example. And I'm sure this thanks is for you and Dr. Hinna. Lots of thanks from the sisters, inshallah.
Well, Jazaki, we would request, if we don't have more questions, that if Ustaza Huda can do dua for all of us in these times. I want to hear from her.
Assalamu alaikum wa rahmatullahi wa barakatuh. Jazakumullah khairan. And also I send to the group, inshallah, according to fiqh, when is it allowed, to do all of these things? And of course, in Islam, most important thing is to keep the life. Hifdhun nafs. This is one of the most important purpose of Sharia, maqasid al-Sharia. So, and go also, I gave you a website of Amja, which is the official site where you can find the answer of those questions. May Allah subhanahu wa ta'ala give us the right decision and wisdom. And as Sister Sadia said, pray istikhara, take istishara also according to fiqh about all of these things when you answer this form. And may Allah subhanahu wa ta'ala give us the Aisha Haniya and Mita Sawiya, the good life, and also the good, Mita Sawiya, the way we die is the good way of dying, subhanallah. And inshallah, I'll try to say some du'as, inshallah. And I asked Alia also to translate the general meaning, because the meaning in Arabic are really very beautiful. May Allah subhanahu wa ta'ala protect all of you. And special thanks to Saadia. She gave me an idea to give you a yes, no question at the end of each class. We give online. Inshallah, I will do that for Muddakir. Starting next year, inshallah, you will have a small quiz after each class. But it was a good idea. Barakallah fiki. Inshallah, bismillah, alhamdulillah, wa salatu wa salam ala rasulillah. Allahumma la yuhzamu junduk wa la yukhlafu wa'duk. اللهم إنا نسألك باسمك الأعظم اللهم إنا نسألك باسمك الأعظم ووجهك الأكرم أن تحفظنا بحفظك وتكلأنا بكلأك اللهم احرسنا بعينك التي لا تنام وركنك الذي لا يضام واجعلنا في أمانك وضمانك وإحسانك اللهم إن هذا المرض مرض كورونا جند من جنودك تصيب به من تشاء وتصرفه عن من تشاء اللهم اصرفه عنا وعن بيوتنا وعن أهلينا وعن أزواجنا وذرارينا وبلادنا وسائر بلاد المسلمين اللهم احفظنا مما نخاف ونحذر فأنت خير حافظا وأنت أرحم الراحمين اللهم احفظنا مما نخاف ونحذر فأنت خير حافظا وأنت أرحم الراحمين تحصنا بذي العزة والجبروت والكبرياء والعظمة اعتصمنا برب الملكوت الذي لا يموت اعتصمنا برب الملكوت الذي لا يموت الله أكبر من كل ما نخاف ونحذر لا إله إلا الله وحده نستغفره ونتوب إليه لا إله إلا أنت سبحانك إنا كنا من الظالمين لا إله إلا أنت سبحانك إنا كنا من الظالمين ربنا ظلمنا أنفسنا وإن لم تغفر لنا وترحمنا لنكونن من الخاسرين اللهم ارفع عنا البلاء والوباء ونجنا من الفتن ما ظهر منها وما بطن Alia, if you would like to translate just general translation you can go then I will continue
Mashallah, that was very fast. This, if I will feel more comfortable to finish translating it and then like send it. But of course, the general dua that Allah subhanahu wa ta'ala doesn't allow us to be defeated by the illness, and that Allah subhanahu wa ta'ala protect us all and protect our countries and give us from His rahmah. This is a very, very weak translation, and I left out many, many things, but you went a lot faster than I thought you were going to go, mashallah. So, inshallah, I'll finish translating it fully, inshallah, and then we'll send it out to the groups, inshallah.
It's important, you know, when we studied about dua, that, you know, you mention Allah with His names and His sifat wa asma. You see the power of Allah subhanahu wa ta'ala when you see your weakness. This is very important. We studied at the end of Surah Al-A'raf, you know, that, you know, the way of dua, how you do it and how you remember Allah subhanahu wa ta'ala. This waba, this epidemic, this pandemic shows us the mighty of Allah subhanahu wa ta'ala, the power of Allah compared to our weakness. So you always remember, you know, ذو العزة والجبروت الكبرياء العظمة ذا الجلال والإكرام. You have always to remember that. Allah الحي الذي لا يموت. Subhanallah, this is very important when you do the dua. اللهم ارفع البلاء وادفع الوباء عنا وعن المسلمين وأنزل رحمتك ولطفك على عبادك جميعا برحمتك يا أرحم الراحمين. اللهم إنا نعوذ بك من زوال نعمتك. اللهم إنا نعوذ بك من زوال نعمتك وتحول عافيتك وفجاءة نقمتك وجميع سخطك. نعوذ بكلمات الله التامات التي لا يجاوزهن بر ولا فاجر من شر ما خلق وذرأ وبرأ ومن شر ما ينزل من السماء ومن شر ما يعرج من الأرض ومن شر ما ذرأ في الأرض ومن شر ما يخرج منها ومن شر فتن الليل والنهار ومن شر كل طارق إلا طارقا يطرق بخير يا رحمن. اللهم إن هذا الوباء وباء كورونا قد غدا من حولنا وأمره بين يديك فحل بيننا وبينه بلطفك وسترك وعفوك ورحمتك واحمي بلادنا وجميع بلاد المسلمين من شره وبلائه. اللهم اشف المرضى جميعا. اللهم اشف المرضى جميعا وخفف عنهم برحمتك يا أرحم الراحمين. اللهم بحق لا إله إلا الله وثقلها في الميزان وبكل أسمائك الحسنى وعظمتها يا من تقول للشيء كن فيكون. اللهم أعد لبيوتك ومساجدك روحها مرة ثانية. اللهم لا تجعل مصيبتنا في ديننا. اللهم لا تجعل مصيبتنا في ديننا. اللهم بلغنا رمضان غير فاقدين ولا مفقودين. اللهم بلغنا رمضان غير فاقدين ولا مفقودين. اللهم بلغنا رمضان غير فاقدين ولا مفقودين. اللهم ارفع عنا البلاء والوباء والأسقام والفساد والزلازل والمحن ما ظهر منها وما بطن. اللهم إن كان هذا الوباء والبلاء بذنب ارتكبناه أو إثم اقترفناه أو وزر جنيناه أو ظلم ظلمناه أو ظلم ظلمناه أو ظلم ظلمناه أو فرض تركناه أو نفل ضيعناه أو عصيان فعلناه أو نهي أتيناه فإنا تائبون إليك فتب علينا يا رب ولا تطل علينا مداه برحمتك يا أرحم الراحمين.
I mean, and this part is beautiful, mashallah. She's asking if it's any like sin that we committed or anything that we've done to bring this onto us, that Allah subhanahu wa ta'ala forgive us, because He's the one that's forgiving and merciful. And she also mentioned a lot of Allah's rahmah, and as she said, the munasib, or the beneficial name of Allah that she called on at that time was that Allah is Ar-Rahman. So in every situation that we're thinking about, that we're in, or that we're asking dua for, that we use the most suitable name of Allah subhanahu wa ta'ala to ask Him to remove it from us. And anything that's coming from the sky, anything overtaken from underneath us and from any direction, that Allah subhanahu wa ta'ala is the one who is able to remove all of this all of this test, this epidemic and everything. And also that Allah subhanahu wa ta'ala allow us to have a Ramadan and not to lose the blessing, that we reach the Ramadan and that we don't lose its blessings. And this is the first time we're in a test like this, probably in any of our lifetimes, and all of our lifetime actually. There's never been a situation all over the world that everyone all over the world in the masajid, she mentioned the masajid being closed, and to bring back this ni'mah and this mercy to us. And may Allah forgive us, and may we all make tawbah And just to insert, she's still making her dua, but just to insert, there was a story I heard of Sahaba long ago in some time period where there was an affliction that afflicted the town. And the Amir, he asked everyone to make tawbah to Allah subhanahu wa ta'ala. And they all made tawbah, and this affliction was removed from them. So, you know, as she said just at the end of this, that Allah subhanahu wa ta'ala, you know, is the one who can forgive. And so we should make the sincere tawbah.
جزاك الله خيرا. اللهم ردنا إلى دينك ردا جميلا ولا تقبضنا إلا وأنت راض عنا برحمتك يا أرحم الراحمين. لا حول ولا قوة إلا بالله، لا حول ولا قوة إلا بالله، لا إله إلا أنت سبحانك إنا كنا من الظالمين. اللهم إننا مقصرون وأنت الكريم، ومذنبون وأنت الحليم، وفقراء وأنت الغني. اللهم تجاوز عنا بعفوك ولا تعذبنا بسخطك. اللهم ارحمنا فأنت بنا راحم، ولا تعذبنا فإنك علينا قادر. اللهم لا تحملنا ما لا طاقة لنا به. ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا. ربنا ولا تحملنا ما لا طاقة لنا به، واعف عنا واغفر لنا وارحمنا، أنت مولانا فانصرنا على القوم الكافرين. اللهم إنا نسألك يسرا ليس بعده عسر، وغنى ليس بعده فقر، وأمنا ليس بعده خوف، وسعادة ليس بعدها شقاء، وعافية ليس بعدها مرض، برحمتك يا أرحم الراحمين. اللهم بعلمك الغيب وقدرتك على الخلق أحينا ما علمت الحياة خيرا لنا، وأمتنا ما علمت الوفاة خيرا لنا. اللهم إنا نسألك خشيتك في الغيب والشهادة، ونسألك كلمة الحق في الرضا والغضب، ونسألك القصد في الغنى والفقر، ونسألك نعيما لا ينفد، ونسألك قرة عين لا تنقطع، ونسألك الرضا بعد القضاء، ونسألك العيش ونسألك برد العيش بعد الموت، ونسألك لذة النظر إلى وجهك الكريم والشوق إلى لقائك من غير ضراء مضرة ولا فتنة مضلة، من غير ضراء مضرة ولا فتنة مضلة. اللهم زينا بزينة الإيمان واجعلنا هداة مهديين برحمتك يا أرحم الراحمين. اللهم ارزقنا عيشة هنية وميتة سوية برحمتك يا أرحم الراحمين. وصلى اللهم على سيدنا محمد وعلى آله وصحابته أجمعين.
Alhamdulillah, in the beginning of this part, again, this is a short version of the very long, beautiful dua that she's making. Alhamdulillah, that, you know, that we're sinners. She made the dua of Ayyub, that we have wronged ourselves, and asking Allah subhanahu wa ta'ala to forgive us. And this is something that he made in the belly of the, you know, of the whale when he couldn't get out. And because of this dua, he kept repeating, Allah subhanahu wa ta'ala removed him from this situation that he was in. Also, she was saying, you know, admitting the sins to Allah, that, you know, we're sinners, and asking Allah to forgive us, and admitting that we have done wrong, and asking Allah to forgive us, although we've done these things. And asking that we have, I'm trying to like take pieces, that we have, you know, a life, you know, that after the death, that our life is we have a good life after the death. And that so many things she said, mashallah, I can't translate that quick, but just that Allah subhanahu wa ta'ala, you know, bring out of this difficulty, that he bring ease for us, and that after, you know, that we find good after this trial that we're in, basically, was the second part of it. Inshallah, we'll go through, you know, I'll go through and translate it at a pace that's that I'm able to. But Jazakillah khair, Ustad, beautiful dua, beautiful meaning, and a wonderful reminder after the reminders from Dr. Sadia and Dr. Hinna, to be reminded of Allah subhanahu wa ta'ala in this way, and be reminded of our sins, and be reminded to call on Allah with his most beautiful names, and know that Allah subhanahu wa ta'ala is Qadir. He's able to do everything. He can remove this from us. And while we're in the situation, that we are, you know, learning from it, and that we are constantly in tawbah, and constantly, you know, trying to repair ourselves, and what we learn from this workshop, to prepare ourselves, because we don't know. And, you know, before the coronavirus, we didn't know before, but now we really see, you know, like our situation is very highlighted now, because every day you hear about deaths in our country and all over the world. So we need to always be in a state of preparedness with Allah subhanahu wa ta'ala, with the things in the dunya, the documents we need, and with the things that we need to be prepared within our souls and with our religion by being in a state of tawbah and always trusting in Allah and always trying to be our best and not taking for granted that we will have time to, continue the way that we have been continuing.
بارك الله فيكم. أستودعكم الله جميعا الذي لا تضيع ودائعه. I leave you with the hands of Allah subhanahu wa ta'ala and as amana by Allah subhanahu wa ta'ala. He's al-Hafiz, al-Wali inshallah. And we will meet again inshallah in the exam. And I can kiss you like this even at the time of Corona inshallah. Jazakumullah khairan. I miss every one of you and you are in my dua also. Keep us in your dua. Jazakumullah khairan. Assalamu alaikum.
Wa alaikum assalam wa rahmatullahi wa barakatuh.